Be still and know that I am here. I'm not a pole. I'm not a bench. I'm not a can. I'm not a hydrant. You walk by as if I don't exist, don't matter, don't share the air around us. My heart beats, paces to and fro. I see you coming. I see you going. But you don't see me. I'm not a pole. I'm not a bench. I'm not a can. I'm not a hydrant. I'm your neighbor. I'm your friend. I'm your loved one. I'm here, lying still, hoping for recognition, respect, love, compassion, humanity, hugs, honor, acknowledgement. What pain do you feel as you step over me to move on? Are you embarrassed to look, to feel, to speak? Stop and share the air. Share the night. Share your love. Share your concern. Share your time. Stop and coexist. Participate in the solitude, the solidarity with another human suffering. Be still and know that I am here.
The poem you just heard was written by our very own Dr. Lohenry. It was written by him last year after one of our group members, Susan, shared with him the experience that we had at the Health Symposium. During the event, we met a woman experiencing homelessness. Her name was Miss Garcia, and what you just heard were her exact words. She felt forgotten, dehumanized, and compared herself to a pole. It can be easy to desensitize ourselves to the severity of this issue in our own backyard, especially when it seems like there are no solutions in sight. But as we've discovered, a problem this complex is going to require innovative and multifaceted solutions. When we think about the health issues that this vulnerable community faces while living on the streets, many things come to mind. Addiction, mental health, sexually transmitted diseases, discrimination related to sexuality and gender. I could go on and on. We wondered, how can we reduce negative health behaviors associated with these issues, and how can we empower people, especially people experiencing homelessness, to continue doing this in their day-to-day lives and in their communities? Our answer: education.
It was our hope to use this project as a vehicle to empower our audience through education. The biggest hurdle we faced was finding data relevant to the homeless population in terms of education. Unfortunately, when looking at Healthy People 2020, the objectives did not coincide with the education of the homeless population. Nevertheless, we used objectives that most closely align with our goal. We wanted to target access to health education in homeless adults in SPA 4 relevant to their specific needs. The closest objectives from Healthy People 2020 was educational and community-based programs, also known as ECBP 10.3, 10.5, and Substance Abuse-9. Increasing the number of community-based organizations, including local health departments, tribal health services, non-governmental organizations, and state agencies, providing population-based primary prevention services of substance abuse. Increase the number of community-based organizations, including local health departments, tribal health services, non-governmental organizations, and state agencies, providing population-based primary prevention services of mental illness. And increase the proportion of persons who are referred to for follow-up care for alcohol problems, drug problems after diagnosis or treatment of one of these conditions in a hospital emergency department, respectively. When trying to find research on the homeless population, you will quickly come to realize that very little has been done in terms of measuring empowerment in this community and measuring the effect education has as a harm reduction tool. It was difficult to assess a baseline. Nevertheless, our literature search led us to multiple studies, including Making Sense of Street Chaos and Ethnographic Exploration of Homeless People's Health Service Utilization, which demonstrated poor health and mortality indices of homeless individuals could be explained by administrative, physically, or attitudinal factors. Another study was How Does Organizational Literacy Impact Access to Healthcare for Homeless Individuals, which showed the direct relationship between homelessness and literacy level. This study demonstrated an increase in literacy level correlated with improved access to healthcare. Our data search revealed 7.5% of adults in SPA 4 reported being homeless and not having a place to sleep in the last 5 years. 29% of individuals reported difficulty in accessing medical care in 2018. We were then ready to meet with our community partner. With our literature search in SPA 4, SPA data, and objectives in order, we reached out to our own street medicine team here at USC. We were then directed to Brody Butler, an aspiring medical student at the Lamp Village in the heart of Skid Row. Ms. Butler is the harm reduction coordinator at the Lamp Village, which serves as a shelter for men and women, housing residents for up to 60 days, providing housing, food, laundry services, as well as various enrichment classes to their residents. These classes included financial literacy to create and maintain personal budgets, to pay bills on a limited income and help clients improve credit and avoid loan sharking, along with other topics to help these vulnerable populations take control of their lives once again. In addition to these classes, the Lamp Village is home to an art club, a music club, and Skid Row Science Club. The Skid Row Science Club holds bi-weekly meetings, hosting various speakers and activities for the furthering of the residents' education. We thought this was the perfect audience for this project. Serving as the Science Club coordinator, Ms. Butler suggested a series of classes. Through our needs assessment, we were able to determine that the health concerns of this population in Spofford at the Lamp Village and Skid Row included genetic components of sex and gender, drug addiction, and sex and STD education. We set out to put together our classes with activities. After the conclusion of our activities and lectures at the Lamp Village, it was evident that there was room for improvement. In the future, we would like to assess the education level of our participants, demographics, the duration of their current housing instability, and follow up with our participants days and weeks after to assess the impact of our presentation and measure if they felt empowered to make healthier, but first and foremost, safer choices in their daily lives.
As we developed our lecture series, we wanted to make sure that we took into account both health literacy and cultural competency. We knew that we would have students from a variety of different educational backgrounds, as well as different cultural backgrounds. We also knew that the health topics chosen by the students could easily become too confusing and complex for us to teach effectively. We addressed these points in a couple of different ways. First, we printed our pre- and post-tests in English and in Spanish in hopes of encouraging Spanish speakers to attend our sessions. We also made sure our lectures were taught at a 6th grade level education. In each lecture, we were very intentional about making sure that we taught in a clear and effective manner without watering down the information too much or missing relevant points. We made short, simple PowerPoint presentations that included easy-to-read graphics, and within our sessions, we incorporated open group discussion throughout, as well as a unique hands-on activity related to the topic we were teaching on. We were also able to adapt as our sessions went on. For example, after our first session, we learned that some students were not able to read, which resulted in those students leaving the session midway through. We addressed this by taking the time to go through pre- and post-test questions with the participants by circling the room and giving them the opportunity to have the questions read aloud, or to ask any questions personally rather than to the whole class. Taking all of this into account, we aim to create simple, effective, fun science club meetings rather than lectures that would not be engaging to our students. Through this project, we promoted self-advocacy in many ways. Using science as a vehicle to understand health topics, we aim to empower the residents to reduce harmful behaviors. We hoped that this knowledge could help guide their decision-making process to make good choices regarding their health. We also provided access to resources in the area in hopes they would continue to advocate for their health and use what is made available to them when or if assistance is needed. We found that using education as a tool for advocacy, though hard to tangibly measure, can be effective in the right circumstances. In this intervention, Brody Butler was and continues to be an advocate for these residents. She was able to identify which health topics the residents were most interested in. She also advocated financially to purchase supplies for the lecture series, as well as small gifts for the residents that attended our sessions.
Throughout the lecture series, data was collected regarding education and empowerment. We asked questions about information taught at each session, as well as 2 common questions addressed across all sessions. Here are the results from session 1. Our pre-test had 17 participants and our post-test had 12 participants. For question 1, our goal was to correctly match 4 or more terms, which 17% were able to do on the pre-test and improved to 25% on the post-test. For question 2, we saw improvement from 23 to 75%. For question 3, there was also improvement from 58% to 83%, and question 4 also saw improvement from 58% to 91%. This bar graph shows an increase in the knowledge across all questions, with question 1 in black, 2 in blue, 3 in red, and 4 in green. This positive correlation can also be seen in sessions 2 and 3. Our pre-test had 9 participants and our post-test had 7 participants for session 2. For question 1, our goal was to correctly match 2 or more terms, which 44% were able to do on the pre-test and improved to 85% on the post-test. For question 2, we saw improvement from 33 to 71%. For question 3, it went from 88 to 85%. And for question 4, our goal was to correctly match 3 or more terms, which increased from 33% to 57% on the post-test. This bar graph shows the overall positive impact our intervention had from pre-test to post-test after our intervention. Our pre-test for session 3 had 11 participants and our post-test had 8 participants. For question 1, Our goal was to correctly match 4 or more terms, which 36% were able to do on the pretest and improved to 62% on the post-test. For question 2, there was an improvement from 45% to 87%. Question 3 increased from 72% to 75%. Question 4 improved from 63% to 87%. And question 5 also improved from 63% to 75%. The bar graph once again shows the positive impact that our intervention had. These results were as expected since our lecture series was designed to educate in the hopes of them retaining this information. To assess the change in empowerment, we were able to identify a strongly positive correlation in the question, learning about blank will help me make better decisions about blank. Additionally, there was an improvement in, do you feel like you're moving closer towards your personal health goals after our intervention, which can be seen in the data below. In session 1, it improved from 88% to 100%, as well as from 77% to 85%. In session 2, we saw improvement from 64% to 75%, as well as improvement from 64% to 66%. For session number 3, there was also improvement from 63% to 87.5%, as well as from 72% to 75%. When combining all those data into one graph, we can see here for the first question, there was a significant improvement in the empowerment that they felt after our intervention. And this can also be seen in our second question when we compare the pre and post test results. These results of our data are as expected because by increasing the education of people experiencing homelessness, we were able to see an improvement in empowerment of the group as a whole.
Our overarching objectives were to help reduce stigma of gender and sexuality within the community, learn the science of addiction, and make safer sex choices to reduce transmission of STIs. The way we measured these objectives were through a pre and post test, and overall, given the data that was just presented, supported that we met our objectives. Each participant survey were measured individually, and we saw an increase in the questions answered correctly in the post test. However, we cannot quantify if the data is statistically significant due to the small sample size and lack of previous research on this population. Within the physical lecture, each team saw an increase in attention and participation of the class as a whole. Our objectives first seemed simple: educate to empower. However, when we were at the Lamp Village and as our sessions commenced, we continually refined the way we presented our material in each session. Why? Because we observed how participants responded with each successive session and noticed a discrepancy in attendees. There were more participants in the pre-test than there were in the post-test. This showed not only during lectures, but also in our results. One barrier that may have contributed to this discrepancy was with engagement due to the various levels of education within our population. We must keep in mind we are dealing with a very vulnerable population, and we didn't want to make them feel stigmatized by presenting material that was not digestible. Some participants could not read, and some felt like there was too much material to learn in one session, so they did not return to the other sessions. Some knew there was a giveaway at the end of our sessions, and once the prizes were given, they left before filling out the quiz. Perhaps those self-eliminated themselves improved our data, or some participants didn't even want to take that quiz, so they may have guessed and potentially guessed right, which could have also improved our data. However, we tried to improve those barriers by decreasing the amount of words on each slide, creating more slides with graphics, as well as creating an environment with an open dialogue with participants to ensure understanding and, as a team, grow together.
As our group was reflecting on our AT-Ed project, we agreed that it had a profound impact on our population in two specific ways. Our data implied that our educational material was effective, and we noticed that in all three groups, our participants were engaged and excited about learning. As we discussed, many of our participants retained the information that was presented to them, as evidenced by the results of our pre- and post-tests that we administered. We felt that their retention likely had to do with the fact that they were engaged and excited about learning. We presented on topics that were identified by our community partner that the residents of the Lamp Village were interested in. So this created buy-in from our audience before we even arrived. We also did our best to create an active, engaging learning environment by presenting our educational material with visual aids, discussion questions, and hands-on activities. Our group also discussed ways that we would implement our project differently in the future. We all shared a common concern. It was difficult to balance the academic research component with our altruistic desire to make an impact on our patient population. Given the nature of our project, we needed concrete data to be able to measure our effectiveness. And many of our participants from the sheltered community experienced literacy challenges, whether related to their educational background, primary language, or their physical limitations. So unfortunately, our pre and post tests were only presented in written format. If we were to repeat our intervention in the future, we would need to identify creative ways to collect data outside of the traditional written format. It would also be important to clearly communicate with all of the participants that the Skid Row Science Club is performing research on the dates of our intervention, and that they'll be asked to participate in a pre- and post-test survey as part of their attendance. Education is about sharing and teamwork. It's about having self-confidence, and it's about asking the question, why?